I'm going to go ahead and introduce our keynote speaker today. The president gets to pick the keynote speaker, and for me, there was really no choice. I've known this man for, long time, I won't even say, 27 years. He actually is younger than me, although he looks much older. And he's got a very interesting background. He's got a very interesting history, and he really does sort of embody all those that wonder are not lost. Forward, hit the forward button. So David started off. He went to medical school. But then he did a psychiatry residency. And he thought really what he wanted to do was help people, but he decided that the help that was needed was really his own. So he sort of dropped out for a while, and he went down to a small Caribbean island and began driving Uber for a while down there. Decided that he really couldn't make a living doing that, so he went back and he went to vet school and became a veterinarian. But then we all make mistakes, David. Got in a little trouble, and some prominent Atlanta socialite, he actually stole her dog and ran off, and so he got in trouble there. So he had to retreat to a small South American country as a haven and harbor for that. But finally got things back together, came back, went back to his medical practice, got engaged in chest wall work and then trauma work, and the rest is history. None of that's true. David did his residency in Atlanta, and I was the fellow at Texas Children's, and my senior fellow had quit. And so I was at Texas Children's with 3 faculty, no senior fellow, and I thought life was really almost not worth living at that point. And then this brother showed up. He came as the fellow the year after me, and it was just like a breath of fresh air. Not only is he an amazing physician, but he's an amazing person. He was an amazing partner and even a better friend. He and his wife Michelle were friends with ours. Their son Michael and our daughter were together all the time, and it just made it bearable. We had we had a great time in Houston, and then, but probably for me, our paths sort of diverged. I took off I stayed in Texas, and he went to Arizona, and called one day and said, the state of Arizona really wants to make Phoenix Children's a trauma center, and I want to do that. It's the right thing to do, and I know what to do clinically, but I need some help structurally, and so got him a great trauma program manager. Came and helped the hospital administration see sort of the value of what he had already told them, and then he created, in my opinion, one of the finest pediatric trauma programs in the world. He continues to innovate. He has developed young people. He's passed his gift on to the next generation of pediatric surgeons and people that are interested in pediatric trauma care. And now he's embarked on this new endeavor, saying that we're at an inflection point as a group where we could do more for injured pediatric children. We need to have discovery. We need to have dissemination, and it's time to put together a network that's going to address these very important problems. And so he's led that, and I'll let him talk talk through all of that, but I can't tell you, the last couple of days I've gotten to spend watching him orchestrate the collection of the brightest minds in pediatric trauma care around a pediatric trauma research network. And the fact that you saw NIH program directors here this morning and that you're going to have time with them through this whole meeting is unbelievable, and an unbelievable testament to sort of his force of will, his interpersonal skills, and just I can't thank him enough. So I look forward to listening to the David Notrika Professor in Pediatric Surgery, Pediatric Trauma Surgery. I mean, how many of you have a professorship named after yourself? That's pretty, and not given by himself, by the way. I mean, actually, somebody else said, that guy's so cool, I want to name an endowed professorship after him that he enjoys. So I want you to welcome to the stage my friend, my brother, David Notrika.
Well, that is an introduction. I was going to be a cardiothoracic surgeon, and so during my general surgery training, I kind of picked up the personality of a cardiothoracic surgeon, and then I got to Houston, and I was I guess kind of like a bull in a china shop, and Todd Maxson, who was my senior fellow, pulled me over one day and said, "You got to stop saying no." He goes, "You need to start listening to these pediatricians and think about what they're saying and consider what they're thinking." And I thought, well, that's a novel idea. But when he a lot of the skills that were required to pull the network together were actually things that Todd taught me when I was in fellowship. So with that, we're going to stop all this nonsense and just talk about some cool stuff. So disclosure, I am a consultant for AtriCure, and I do get royalties for patents related for Pectus from KLS Martin. But I don't think any of that's relevant to what I'm going to talk about today. We're going to talk about the history of non-operative management. And we're talking basically about the progress that we've made in pediatric trauma research and pediatric trauma in general. So we're going to talk about the history of non-operative management and kind of an example of the stair-step progress that we've made, and that it's not just a linear trajectory. We're going to look at splenectomy rates and what that tells us about the rate of progress. We're going to look at pediatric trauma mortality on a kind of a population level, and compare that to what's driving that. And we'll also look at trauma quality, trauma research volume, and the quality of the research that we're seeing. We'll talk a little bit about the impact of injury prevention and advocacy's impact, and we'll talk about the impact of giving less crystalloid and what that tells us about collaborative research. And then we'll talk about some traumatic brain injury and stem cells, and what that shows us what can be accomplished. And I'll go over some of Chuck Cox's work in that. And then we'll talk about what we don't know and future steps. And then I'm going to conclude with AI's impact on our future. So it's not just everybody else that it's going to affect. It's going to affect us too. So the landscape in the 1960s was very interesting. The indications for taking out a spleen were pretty straightforward. Vital signs in laboratory studies, including roentograms, were of very little use in deciding the need for surgery. Let me say that again. Vital signs were of very little use. 1960. So in the 1970s in Toronto, at Sick Kids in Toronto, Doug Simpson published this series describing 32 cases of non-operative management of the spleen. And I will tell you that was groundbreaking, to have 32 kids where they injured their spleen and they didn't get their spleen taken out. Well, most of them didn't. They had about 25% of them did not require surgery. But everything that's been said has been said before. We have to keep saying it because no one was listening. So adoption really does take a long time. So it turns out in 1882, Gross, who was generally considered the founding father of pediatric surgery, said non-operative management for spleen injuries should be treated with bed rest and a mild diet for minor injuries. That was 1882. Now the caveat is he also recommended lead acetate and ergot, which is a psychoactive fungus, that's the picture, and opium for lesions. So I don't think he quite got it right, but he did get part of that right, and the surgery was performed only if necessary. But it wasn't in 1971 that we first came up with the concept that maybe we shouldn't operate on these kids, because in '68, this guy whose name I can't pronounce up in Daya observed, I love this quote, "It's intriguing that in most children with splenic lesions, that bleeding has stopped by the time of laparotomy." Didn't stop them from taking the spleen out, don't get me wrong, they still took the spleen out. So, he actually had some theories that maybe it was the hypotension, the clot formation, the gluing effect of the omentum. The omentum just kind of sticks to this spleen, and there's a perisplenic hematoma that contains the spleen. And then my favorite is that the spleen capsule was intact, so they never actually bled anywhere anyway to begin with. But also, again, that spleen comes out. So splenectomy was the norm, and then and that was throughout the 80s. There was actually very little adoption, even though in the 70s there was clear evidence and clear recommendations. A few people were doing it, but it certainly wasn't the norm. Stilianos in 2000 with the APSA Trauma Committee basically said, look, the problem is not lack of knowledge, it's implementation, and published some evidence-based guidelines for resource utilization. And so he came up with what was the APSA guideline at that time, which was grade of injury plus 2 is how long you need to be in the hospital. That's a long time if you have a high-grade injury, especially if you guys are currently taking care of patients with spleen injuries. But he strongly advocated for not operating on kids, and that was really important, and it was also a game changer. But he didn't really give instructions as to do it, and there was a lot of discussion. So that was 2000. 2008, the group from Arkansas. I think this may have been pre-Todd, or maybe around the Todd was there. They came up with throwing out the grade book, and basically they recommended don't make management based on grade, make it based on how the patient's doing. Look at those vital signs. Everything's been said before, but nobody was listening. And it turns out even in Arkansas they had said this before, because they actually published this paper in 2001 in an even better journal that showed that there were prospective results that you could manage solid organ injuries by hemodynamic status and not by CT injury grade. So even then, you got to just keep saying it. It's kind of ridiculous. Their guideline, they did provide a guideline. It was kind of like, if you're stable, you do this, and if you're unstable, you do that. And this is a little bit too small to read on purpose. But what you need to know is that they gave a little bit of guidance towards what we should do. And there were not a lot of contingency plans. It was give blood until their hemoglobin is greater than 7, and they're going to be fine. Okay? Give blood and they stay unstable, they're not going to be fine. And that was the algorithm. But we looked at how little adoption there was, and we were like, well, we need to do a little bit more around that. And so I got together with Todd and a bunch of other people, Bob Letton, some other people, actually a lot of people who were in the room, and we wrote this paper where we developed a guideline. We took the Arkansas sketch and we made it into a real guideline, and then we submitted it to the Journal of Trauma, which laughed at us. And they're like, yeah, we're not publishing this. And they said, but if you make it a grade study, then we'll consider it. And I'm like, oh yeah, absolutely. And I had no idea that grade study is like hundreds of hours. You have to pull every single article that was ever written. And this was just at the beginning when East was starting to do all their grade works. Most people do one grade study and they're done. Anyway, we did it and we got it published, and that article I think made a difference. It's been published, it's been cited almost 200 times now. And then after that, we prospectively enrolled 1,000 patients who had a spleen or liver injury. And what we found is that the failure rate for bleeding was about 3.4%. And then another 3.4% failed for other injuries. They had diaphragmatic ruptures or other injuries, but the overall failure rate was about 9.5%. And so we really started to push for non-operative management, and we got that rate down. At the time we published that the failure rate was around 7%. We then went back and added some unstable patients that we had not captured, and I think the real rate during that time was probably around 9.5%, because we only were looking at non-operative management. The patients who weren't candidates for non-operative management, we didn't include initially. We went back and added those later. So one of my partners, I think I dropped a slide out by mistake, but Justin Lee at Phoenix Children's went to determine how we're doing it. And he looked at contemporary management of blunt splenic injuries and looked at the factors that were contributing. And he went to the Healthcare Cost and Utilization Project and pulled the kids database for 2012, 16, and 19 for kids less than 17. And he looked at a lot of stuff. He looked at demographics and injury grade and hospital factors and patient factors and all that stuff, and just kind of divided it up into see who was getting non-operative management and who was getting operative management. And he pulled 8,000 cases of blunt splenic injury, mostly boys. 3/4 of them were taken care of at adult hospitals, and 1/4 at children's hospitals, and a variety of different grades. And what he found is that the number of blunt splenic injuries being taken care of at Children's Hospital during this 7-year time frame went up incredibly. So it went from 14% to 51% of the high-grade injuries. And I think that really is when we look at this room, and we can all pat ourselves on the back for that, because now we're actually taking care of those patients. So with that, what happened with the splenectomy rates? And so it turns out that the adult hospitals, which you see in yellow here, actually went down, a reasonable amount. I mean, not statistically significant, but it's definitely a trend towards lowering the splenectomy rate. But the splenectomy rate at children's hospitals went up. But there's still this big gap between the yellow line and the bottom, the dark blue line, and so there's a difference in the management. Overall, the national trend, there hasn't been much progress in the last decade on the splenectomy rate, and we're still kind of hovering around that 7% mark. So when we ask the question, are we making progress? I think part of it is that we have to answer the question of who is we? Okay, is we the pediatric trauma centers, or is we the world, the United States in general? And so pediatric trauma centers are still doing it better. But I can quote you 14 papers that show that pediatric trauma centers do it better, and I'm sick of hearing it. And so now the question is why? Why are we doing it better? And so this is another study that I did with Justin Lee, and we looked at the factors that were associated with operative management. And the truth is, I had gotten super busy, and I said, this study needs to be done, but I don't have time to do it. And Justin Lee and Scott Eldridge, one of our research fellows, did it. And what you see here is that the gross splenectomy rate at adult hospitals is 3 times what it is in pediatric hospitals. And being an academic versus a non-academic center makes a difference as well. And things like the grade of injury are factors, but so is blood transfusion. So blood transfusion versus no blood transfusion has an odds ratio of 4.4%. So if you get transfused, you're 4 times more likely to go to the OR. Well, that makes sense, right? Well, no, it doesn't. It shouldn't be 4 times. It should be like 100 times, right? Everybody should get transfused before they go to the OR. Well, maybe they're not getting transfused before they go to the OR. And so we looked at the TQIP study, and we only pulled the unstable patients. We didn't look at the little people who weren't bleeding. We're looking at the patients who were hemodynamically unstable on arrival. And it turns out that 1/4 of them go to the operating room and get no blood products. And another large portion get blood products so quickly that it's not clear that they even had a trial of non-operative management. And so I just think this is crazy. And so when we talked about the atomic guideline that we put, we said, all right, give 20 per kilo of crystalloid, and then if that doesn't work, give blood. And then way down there, if you fail after 20 per kilo, then you go to the operating room. A lot of patients are going to the operating room without getting blood. So this is a little bit of scientific stuff that you need to understand. And so there's univariate analysis and multivariate analysis. Univariate analysis just says, does this factor matter? And multivariate analysis says, does this factor matter independently? Or is it just moving along with something else? And so what we found was that when we looked at blood transfusion, it was very significant in the univariate analysis and non-significant in the multivariate analysis. So follow me. So you have unstable patients. Patients are getting a blood transfusion. It makes you look like you're 4 times more likely to fail because you got blood. But if you control for the other factors, transfusion is no longer a risk factor. Essentially, getting blood, if you're unstable, getting blood is protective against having your spleen taken out. And so when you do this analysis again, you realize that the difference between adult trauma centers and pediatric trauma centers now is not statistically significant. So the difference is that adult trauma centers see a child in shock, they assume they're still bleeding, and that they need to have their spleen taken out, because that's what happens in adults. A lot of adults in shock are still bleeding. It only means that they've bled. And so we're back to this observation from 1968 that it's intriguing that most children with splenic lesions have stopped bleeding by the time of laparotomy, i.e. the laparotomy that they did not need. All right, so we're making progress on spleen slowly and in a stair-step sort of way. In 2022, we updated the guidelines, and this was published in Seminars in Pediatric Surgery, which Todd Maxson edited for them. And so a couple of changes. We recommended CT scanning based on the prediction rules, the PEDS SRC Chris Strex rules, or the PECON rules. Should decide if you even get a CT scan. And then we defined some criteria for who can be discharged from the emergency room without being admitted. So there's some grade 1 and grade 2 injuries that do not need to be admitted, and it lays out the criteria for who can go home. And then it eliminated the repeat hemoglobin checks. So, and it also kind of set criteria for discharge, so that, like if your shock index needs to be under control, and some other things for discharge. I highly recommend it. It's good reading. So we're making progress in spleen. Are we making progress in mortality? And so when we look at our mortality, our deaths by year, what we see is that cancer, which is in the blue here, and it's small on this graph because they don't have as many deaths as we do in trauma. Their cancer deaths are actually down by about 22%. So in the last 2 decades, cancer has made an incredible amount of progress. Trauma, not so much. So trauma deaths are down about 6%. There was a period of time when we were making really good progress. But we've lost that progress, and so the results are mixed, but certainly not evidence of sustained progress. You might know what was driving that decrease. Motor vehicle fatality rates. And so when you looked at the 15, 16, 17-year-olds during that time period, the population-based number of kids dying in motor vehicle crashes was really plummeting, and that was really good news. And so we tried to figure out what the impact, what was driving that. The first thing you need to know is that it wasn't just limited to pediatric patients. So the pediatric patients at 16 to 20 cohorts in blue, but that 21 to 55 cohort that I was in at the time was dropping tremendously. So it wasn't just a PEDS-related phenomena. So what was making the difference? So we did a study to look at all kinds of things, and we looked at every kind of law, that we could find and other things, and we kind of parsed it out. And what we found is that lowering the blood alcohol level was the big driver. So when you drop the blood alcohol level for drunk driving from 1.0 to 0.8, it made an incredible difference in the number of pediatric deaths. And when I presented this at AAST, somebody said, well, is it all those people that had a blood alcohol level of 0.09 that were killing the kids? and the answer to that clearly is no. But I do think that it changes the mindset that you can't go out and have 2 drinks and drive home. That's not gonna fly. Per se, alcohol laws. So basically, if you don't have to prove that they were impaired and had a blood alcohol level, if you can just take the blood alcohol level itself, that law that says you're DUI actually makes a big impact as well. Those red light cameras that we hate so much, they actually do save lives. So do seatbelt laws. And then graduated driver's license is protective for young drivers. So 16 to 21 GDLs actually do make a difference. I think almost as interesting as the things that don't make a difference. So increased enforcement of DUI laws do not matter. Mandatory education is pointless. Vehicle impoundment does not work, nor do those interlock devices, those things where you blow on the breathalyzer to start your car, no difference. Underage alcohol laws also don't impact this, and neither do the speed cameras. So the red light cameras, yes, the speed cameras, no. I think that there's a tendency to just throw laws at things and never look to see whether or not they made a difference and peel those off of the books. But that's neither here nor there. All right. So the other problem, and you saw a big uptick, that it wasn't this wonderful sustained low levels of mortality. You saw that the mortality rate from trauma started to go up. And unfortunately, even as we've done very well in motor vehicle collisions, now those gains have been set by firearm injuries. And so this is one of the 12,000 versions of the same graph that was published in the New England Journal that you can all pull yourself from the CDC data, basically showing that the number of firearm deaths has started to skyrocket, and that's really the driving force. It's now the #1 killer of kids. What about research? Are we making progress in research? How much PEDS research is being done? Well, the number of publications, and this basically shows cancer in the blue and trauma in the red. So we are definitely increasing the number of trauma publications. Cancer is doing better than us, but we're doing reasonably well. And I started to really think about what's driving that. Why are we getting more research? And maybe it's 10 years ago today we started the Pediatric Trauma Society. Maybe there was just kind of a growing interest in pediatric trauma. But I think that part of it is really just the number of pediatric trauma centers. So when you look at this time frame from 99 to 2015, we've increased the number of pediatric trauma centers from 14 to 53. And there are currently about 77 trauma centers. It's really hard to get that data now. It used to be a piece of cake. You just go on the ACS's website. Now it's very opaque. Like you really just have to count up all the centers yourselves. It's really time consuming. I don't recommend it. But you see, as we added the increased number of pediatric trauma centers, the number of pediatric trauma publications went up. And part of that is that if you want to maintain your level 1 status, you've got to do pediatric trauma research, and I think that's a really good thing. When it comes to high-quality studies, the randomized controlled trials, we're not seeing big changes in the number of randomized controlled trials at a high level of scientific evidence that's being done. This was a PubMed query looking at pediatric trauma as a keyword and then filtering out for all of the for pediatric patients only. By contrast, the number of randomized controlled trials in cancer has gone up tremendously. So in 2000, CCG-POG, the Rhabdosarcoma group, and the NITWITS, which is the Wilms tumor group, came together to become COG, and you see this exponential increase in the number of randomized controlled trials, high quality stuff being done. So, we looked at mortality, but mortality is not really the only measure. I think non-fatal injury is important as well, and we're making a little bit of progress on that. The areas that we really see impacting the injured patients that we see in our trauma care is the mechanisms. Motor vehicle collisions are making up a large portion, as are non-accidental trauma and peds, and we'll talk a little bit more about that towards the end. But a deep, dark secret about measuring how we're doing is that mortality, most of these deaths are not preventable after they occur. They might be preventable before they occur, but by the time that we see them, they're not preventable. And many of them don't even come to our trauma centers. But there are a lot of kids that are injured. And so what about other areas that can we make progress in? Or have we made progress in? So in 2020, this study about timing and volume of crystalloid and blood products in pediatric trauma was done. And this was done by EAST. So and EAST they have a multi-center trials group, and they do a lot of really good research. They're primarily adult focused, but this was a PEDS project. There are a couple of things about this. This is 24 centers coming together to do research. And what they found is that if you give more than one bolus of crystalloid, it was associated with an increased need for transfusion, extended duration of mechanical ventilation, and longer hospitalization. And we've seen this in various ways where when we don't give them a 20 per kilo bolus and a 20 per kilo bolus and a 20 per kilo bolus, and then we're shocked that they're coagulopathic. When we stop doing that, a lot of our patients that we gave blood and we gave balanced transfusion actually tended to do better and didn't go on. A lot of them actually didn't go on to need massive transfusion, depending on how you define it. That's how much better they did. So this type of research is really important, and it's also difficult to do. Each crystalloid bolus after the first increases the odds of being on the ventilator, and then longer time to transfusion. So it's not just did you transfuse them or not, but if you transfuse them late, it's also associated with extended ventilator duration. And so the data supported a crystalloid sparing strategy, which actually was the same strategy that we had advocated for in the atomic guideline that raised a lot of eyebrows, and the reviewers didn't really like the fact that we were giving blood so early. But here we are, decades later, and giving crystalloid was bad, and we finally have proven that. So we're making progress on resuscitation, but one of the reasons that I love this, and the thing about this study where I really think we're making progress, is not just the fact that that we now know a little bit more about not giving crystalloid. We're making progress because 24 centers came together and worked together to do the study. And then they published this work that was done with 45 authors in a journal that's trying to limit to 9 authors. And if you've ever participated in a multi-center trial and done the work, it's a lot of work. And there's a lot of controversy as to what we need to be doing with multi-center trial authorship. But I don't think that limiting that authorship is going to be the answer. We'll talk about that at the end. So progress on massive transfusion, the answer is yeah. Matter of fact, we actually have a long history of making progress when we go to war, which is very unfortunate. But if you look at previous conflicts, the Korean conflict, Vietnam, and then Desert Storm, Iraq, we actually do make progress when we learn from our military physicians, and that's why they're so valuable, and they're so incredibly valued at AAST and the adult trauma organizations. But there's also a lot of kids that get harmed during war. And our U.S. military physicians do take care of a lot of injured kids. And Neff actually, Lucas Neff, who I think is still here, did some pretty incredible research by using the military databases to figure out if we can improve pediatric trauma care based on the military experience. And these are actually some of his photos, and I'm appreciative for that. They compared their early experience in the war from 2001 to 2005 to late experience, which was 2006 to 2013. And they saw increases in injuries from bad things like explosions. IEDs were really starting to become more and more prevalent, and kids were getting harmed. They saw more head injuries, and their ISS went up. And what they found is that all-cause mortality went down during the process, during the course of the war, despite more severe injuries. And they really attributed a lot of that to their massive transfusion protocols, where they're using balanced resuscitation. So in kids, they were seeing improved survival. And I think that also kind of mirrors what we're seeing in the civilian population, where we're using one-to-one transfusion. Some places are using whole blood, low titer whole blood. Those are definitely coming directly from the military experience. So when they did their study, they basically queried the Department of Defense registry from 2001 to 13, and they pulled 4,990 injured pediatric traumas. So 5,000 children were pulled from that database that are under 18. So that is a really incredible. I think it was eye-opening. I didn't realize that many kids were being injured, but they are. And then 1,100 of them were transfused, and that's what constituted the study. And I think that this type of pulling this type of military registry really shows that we are making progress. Forward. I don't love that it's due to war, but I do think it's really important that when this happens that we take the available data. So another place that we're clearly making progress is in traumatic brain injury, and so the stuff that I'm going to be presenting is not. I was a co-author on this, but this is clearly Chuck Cox's work. And Chuck Cox is the George and Cynthia Mitchell Distinguished Chair in Neurosciences, but he's also the Glassell Family Distinguished Chair in Pediatric Trauma. So at UT Houston. So he may not have a chair named after him, but he does have two chairs, which I thought was kind of impressive. I didn't know you could do that. Anyway, he did, we're going to talk first about his phase 1 trial. So he did this phase 1 trial that was published in Neurosurgery in 2011. Don't forget the time frame, by the way. So this trial is 2011. It takes a long time to do this work. And basically, they took 25 patients, and they took 5 controls, and then 5 patients got bone marrow derived stem cells. So a bone marrow derived stem cell is when you take a patient, you do a bone marrow harvest. You then process it, or you give it to the bone marrow lab, and they get rid of the big giant cells and the small cells, and they send you back the bone marrow cells of the correct size, and then you reinfuse it through a peripheral IV. And this is just an aside. This work. Chuck was telling me about how this work started, and he pointed me to some articles, and they had taken these stem cells and saw improvements in animals. And so then they did, and I don't think it was Chuck's work, I think it was someone else. So someone else radioactively labeled those stem cells to figure out how the improvement is. And then they gave back the stem cells. The animals had a sham injury, or had a sham injury or a real injury. They gave back the stem cells. And they found that the stem cells had actually replaced the bad cells, the injured cells in the brain, because the radioactive tracer was in those cells, and so they assumed that they had basically differentiated into neurons. Yeah, that's actually not what happened at all. So what actually happened was that the stem cells that they gave essentially died, and they gave up the radio tracer that was taken up by the neurons that made them look like they had replaced, and actually that is not the mechanism at all. But there was quite a signal there, and Chuck Cox realized that there was an important signal, and so he continued to do the study. You give the stem cells peripherally, and they end up in the spleen, and from the spleen they kind of start tweaking the inflammatory response. And so that was kind of the mechanism, but it's kind of a cool story. So anyway, you got to do bone marrow harvest on these patients. So you identify the patient with, early, you harvest the bone marrow, it takes about an hour, you process it, and that takes about 6 hours, and then you reinfuse it. And you have to reinfuse in this window between 36 and 48 hours. And Chuck picked as his outcome measures some really complicated stuff. And so he did MRI scans at 1 month, 6 months, and 1 year. So for this study, 1 month and 6 months post-injury. And he did functional and cognitive outcomes, and he looked at cytokines and cool stuff, and corpus callosum volumes, and all kinds of neat things, and found that there were no serious adverse events, and there was some mild pulmonary toxicity that was not clinically significant. And but what he found in the treatment group is that even though they had a greater ISS, that they actually had improved structural preservation of their brain. So, and basically improved outcomes. And so he kind of proved, safety and feasibility. The reason that he picked brain volume is that when you have a severe traumatic brain injury, so your GCS is 8 or less, you're going to lose about 17% of your brain. It's going to be replaced by fluid. You're going to look at a CT scan later, and what you're going to see is that a lot of that brain over the course of the next year has gone away. And the goal was to prevent that loss of brain. So he did the phase 2B trial that was presented at APSA in 2022 and called Autologous Cellular Therapy for Severe Traumatic Brain Injury, phase 2 clinical trial. And it's complicated, but the process is really not that hard, and I think a lot of the people in the room could probably do it if this ever gets FDA approval. So basically the protocol was 2 centers. It was his center in Houston, and we did it in Phoenix, and basically enrolled 50 patients with severe traumatic brain injury. And we did MRIs to look at preservation and kind of look at the volume loss. And this is just an example from another study showing the natural course and the natural loss of volume that happens when you have a severe TBI. Same time frame as before, so an incredibly difficult study. I will tell you that it was, and I told this story at the A+ meeting for reasons, I don't know if they had this experience in UT, but my early patients that had severe traumatic brain injuries had also lost a parent in the car accident. So getting consent was extremely difficult because the surviving parent is making funeral arrangements for the mom, and I'm getting consent to do a study on their kid who's in a coma. So it's rough stuff. Doing research isn't necessarily easy to do. Anyway, the enrolled 50 patients and 33 made it through all of the follow-up. And what he found was that the ventilator days, it was a 3-day reduction in time on the ventilator. Now this is a double-blind randomized controlled trial. The family doesn't know, the ICU docs don't know, the patient doesn't know. Nobody knows whether they had us just make an incision on their skin or whether or not we actually harvested bone marrows. There was a 16% reduction in ICP monitoring days, which is a surrogate for their brain swelling. And so their ICP monitors came out 1 day earlier, and they had a 3-day reduction in their time in the PICU. Now, the PICU docs didn't know if they got stem cells or not, but they're getting out of the ICU 3 days later. And so let me just go tell you. So in pediatric surgery, we know that patients follow a very specific timeline for swelling. So their bodies, after I do a laparotomy on a patient, they are in positive fluid balance for the first day and the second day. And by day 3, if things are going well, they're usually in neutral fluid balance. And then by post-op day 4, they're starting to diurese. That fluid that is located peripherally is starting to go back into their circulation. So that's a typical course with a peak around 3 days. But in brain injury, the peak swelling is actually at 5 days. And I was like, wow. that's different. And there's definitely something going on different in brain swelling that's probably contributing to this, and maybe that's something that we can turn off, and maybe that's a factor. Anyway, so going back to the study, the white matter volume at 1 year was significantly preserved. So the placebos basically lost about 15% of their volume, and the patients who got treatment only lost about 7% of their brain volume. And and it doesn't take a genius to let you know that if you have more brain, you're probably going to have a better functional outcome. But and there were also on functional MRI also showed that there was preservation of the corpus callosum streamlines. So on functional MRI, you're basically seeing things move, and you're seeing that there's preservation of the connectivity between the two brains. But like I said, more brain's better. And so the 1 year outcomes, when we used GOSE, we looked at the placebo, and 57% of these patients had what was considered a good outcome, whereas the treatment group, that went up to 71%. So that is a statistically significant difference and a clinically significant difference in the outcomes for brain injury. So we are making progress. Chuck Cox is working very hard to get a phase 3 trial done. And I'm hoping that within the careers of people in this room that we will be using bone marrow-derived stem cells to improve the results of traumatic brain injury. Who's doing the work? Well, it's not this was a study that was done by Ahmed and published in a World Journal, and it turns out, Upperman won the award for most publications. So that's, I don't know if you can see his name down at the bottom, but that's him at the bottom. And then J.J. Tepes came in second, and obviously he was a giant in the field of pediatric trauma surgery, which is why that we have the Tepes lecture here at the Pediatric Trauma Society meeting. But there are a lot of people in this room that are doing that work. This study was published in 21. I think Aaron Jensen would probably be on that list now, and some other great researchers. PCARN also kind of showed us, they set the bar and they showed us what could be done. And, PCARN is a very successful collaborative that's well funded by the NIH as well as other mechanisms. They have line item funding, and they work on a series of nodes. And some really important people, again, Dr. Upperman, Dr. Bird, Dr. Chuck Cox, Peter Ehrlich, who's in the room, David Mooney, and Jonathan Groner wrote this article that got published simultaneously in the Journal of Trauma, Injury and Infection, which is now JTACS, the Journal of Trauma and Acute Care Surgery. They published it simultaneously in that journal and the Journal of Pediatric Surgery. It was called Pediatric Applied Trauma Research Network, a Call to Action. And so they felt that the development of a pediatric consortium similar to what PCARN had was the next logical step in lowering injury mortality and improving care. I asked AI about pattern, and it said it's a proposed research consortium that would address the lack of a national pediatric trauma research agenda. And so this was done, basically a month ago, and it said it's still proposed. So here we are 15 years down the road, and there's still not an organization that fulfills the criteria. I don't mean to say that we're not doing research. So like I said, the amount of research that we're doing has gone up tremendously, and in the Midwestern Pediatric Surgery Consortium, the Western Pediatric Surgery Consortium, the PEDS SRC, Atomic Plus, East, Western, we're all doing some. So it's not like it's not being done at all, but we're not knocking it out of the park. And then we look at what's being done by PCARN. Most of the studies are all very early pre-hospital or emergency department studies because they are an emergency care network. And the reason they're doing trauma research is because we're not. And so, we really need to start looking at what we can do to bring the ideas of these visionaries into reality. You got to look up, Jeff. This is your pictures on the. Okay, all right. So we have to figure out what we can do to bring this to fruition. And they really nicely outlined where this network would fit. So you see in the red circle is basically we're not looking to replace PCARN. We have some overlap with PCARN. We're not looking to replace CAPCARN. We are looking to carve out the space of injured patients, the non-ICU patients, the patients who have pediatric surgical problems or neurosurgical problems, the spleen, pancreas, liver injuries, the solid organ injuries, the kidney injuries. There are a lot of patients that are not specifically carved out in the wheelhouse of these other institutions. So what does an applied research network look like? I think COG is a good example. So COG has done great things in lowering mortality over the decades, and their goal is to cure all children and adolescents with cancer, reduce the short and long-term complications of cancer treatment, and determine the causes and ways to find and prevent childhood cancer. And I think you can just strike through cancer and put injury in those places, and I think that kind of really defines where we could be. So Atomic Plus is not the PATRN that was envisioned. So I asked GPT to give me an appraisal of Atomic, and it said, studies like the Abdominal Trauma in Children study in the 1990s helped set the stage for modern research into pediatric trauma. I thought that was brilliant, except that that's not what Atomic stands for. It stood for Arizona, Texas, Oklahoma, Memphis, Arkansas Consortium, and it was not around in the 1990s. We didn't form it until 2010. So, I think with AI, we have a little bit of a ways to go before we get any accuracy. But I gave it another chance. I asked ChatGPT. I said, "Well, can you just map out where the Atomic sites are?" And so it did. This is a GPT map of hospital locations. There's Children's Hospital, and Loma Linda, I think, is in Arizona. It's interesting. So we're not quite there yet for AI. And so anyway, so what organization could become PTARN? What organization could morph into this role? And so the Pediatric Trauma Society, here it's an organization that has it's unified the implementation of trauma guidelines. It has a broad representation of people. It is an organization that allows us to come together and discuss important things, and it also has an important research reporting mechanism. So it's a possibility. The Children's Institute is another organization that is a philanthropic organization within Wake Forest, and it has strong financial and logistical support. So I don't know if you guys know this, but Childress actually helped, logistically helped start the Pediatric Trauma Society through a couple of meetings, and they're really good on the philanthropy and the logistical end of things. East has a long history of supporting multi-center trials, and their multi-center trial groups is very important, but they don't really focus on pediatric trauma so much. And then Atomic Plus was a consortium that has done a lot of studies, but we needed something different. So none of these were really kind of right for fulfilling that mission. The limitations of Atomic Plus were that we were too small. We were too elitist, and matter of fact, nobody could figure out how to join. I'm still not sure how Katie Russell joined. She just found out that we were meeting, just started coming to the meetings, and we're like, oh, okay, yeah, you're a member. We didn't have much structure. We were always self-funded. And every time that we did a study, we had to get a new data use agreement, and we had to get new contracts. The legal departments didn't like this wording, and they wanted to capitalize this and not capitalize. It was painful. And then the other thing that happened was that data sharing was a problem, because you do a study, and the relationship would always be between the lead site and the individual sites. And so if someone else wanted to do a study, that was a challenge, because you didn't have a data use agreement between hospital B and C. You only had it between hospital D and all the other hospitals. So, when we were figuring out what the A+ network needed to be, Todd Maxson actually came up with the idea of expanding it, and he basically told me that he was too busy to do it and that I needed to do it. And I'm like, yes, sir. I think, inclusivity is important. So membership is by commitment and ability. And so the applications will open every fall to be a member, and not every center has to do every study. So because this is elitist in the sense that now you're like, all right, we're going to do 20 studies, and you're like, I can't do 20 studies. And so we structure it in such a way that you can right-size it for your institution and what resources that you have. We have a global data use agreement, and it's embedded into the membership contract. If you can't give me a data use agreement, you cannot be a member of A+. Okay, because it just impairs the research too much. We have a unified data coordinating center that is provided by Wake Forest and in coordination with the Children's Institute, and they're doing that for us at no cost. Data coordinating centers are very expensive, and the resources that John Petty brought to bear on this were quite incredible. We will focus on increased funding for research, so not just us getting more funding, but actually trying to grow the pot of funding for pediatric research because it is incredibly underfunded. And we're still working on getting use of a central IRB, but we will navigate that and get that done as well. Wake Forest has made it clear that they can help facilitate that. The risks, there are a lot of risks. We can fail to garner the funds. We can fail to keep the network together. There could be, infighting. But I would much rather do this with pediatric subspecialists than my adult colleagues. The author limitations by journals are a problem. So, this is a network of 28 hospitals. And so, when we do larger studies, all of the journals want multi-center trials, but then you go to publish, and then you have to, basically beg for permission to go past their 9 author limit. I do not think that that's the way forward. The author limits are the way forward. I'll talk about that in a second. There's also the possibility of the failure of the hospitals to continue to support it. So right now, each of the hospitals is paying to join the network, and we think that the long-term return on investment will be good. We thought that they'd probably start to see a return on investment in 3 years. Julie Leonard was at our meeting, and she said, she's the head of one of the main researchers in PCARN. She's like, yeah, it's more like 10. I'm like, okay, so that's another risk. And then also the risk of losing ACS support for research. So when, built into your level 1, your verification is that you are committed to doing research. And we've seen that when the ACS drops requirements for things like getting pediatric specific trauma CME for your orthopedic or your neurosurgeons, that the funding for that basically goes away, and then those specialists stop coming to the meetings. And so if ACS were to drop their requirements for research, you probably would see less enthusiasm for hospitals supporting the research that needs to be done. What it's holding up progress, authorship limits. In the 1980s, it was common to have authors, 2 authors, on papers, and now we see many more authors. But limiting to 9 authors really discourages the type of multi-center research that we're talking about. You can go, so PubMed allows you to enter collaborators who don't show up as authors on the journal. But the problem is that hospitals and C-suite people don't really understand collaborators. They don't value that. Academic centers don't really know what to do with collaborators as opposed to authors. And I also think that no one who picks up that East article that has 48 authors thinks that 48 people wrote the study. The reader knows that the people who are on that as authors did a lot of work. okay? But it's not in any way disingenuous to list them as authors. They meet the criteria, which is that they enrolled patients and they went through the IRBs and they did a ton of work to make sure it got done. I do think that acknowledging them as authors is important. So anyway, the future, we don't know how things are going to turn out, but we do need to try. And I think this is, I don't know that, Atomic Plus won't get a second shot at this. This is going for the gold ring. And, we've made more progress in the last 20 years than we have in the last 20 centuries. But I do still think that there's a lot more work to be done. And I think that this network is going to be the one to do it. The reason that we do this is that there's still 7.5 million children that are treated for injuries in the U.S., and it's a $23 billion a year problem. Traumatic brain injuries, you're talking about 40,000 emergency department visits every year, 30,000 hospitalizations, and another 3,000 deaths. And the patients that survive really do have impairments that infect them for the rest of their life. And there's a lot of variability in how that manifests. It may be emotional instability, it may be an inability to read, it may be an inability to walk. But there's impairment even in when we look at these survivors of severe traumatic brain injury, we know that on average they've lost 17% of their brain. And that is not gonna go quietly, and it's not going to go well. So I think we're also starting to see areas where we can make a difference. The stem cell study, the multi-center trials, the lowering of splenectomy rates, and I think that that's also, why we do it now, is because we're starting to see progress being made. We're seeing opportunities. I think our obligation is not just to deliver the best care possible, but to make what is possible better. And I do want to shout out to the Children's Summit for facilitating our development. They brought together not just pediatric surgeons, but PCARN researchers. The NIH was invited. The NIH came on their own expense. They could not take our money, so don't let me imply that we gave them any money. They paid to be at the conference, which we're incredibly grateful for. HRSA representative, the Toyota Foundation was there. Center was there. Eileen Bolger representing Center. We had rehab specialists, neurosurgeons, we had a resident, we had statisticians. It was a really great chance to get together and learn the best ways to put together a network. So we're making progress on research outcomes and in patient care, and the progress is slow, it's uneven. I'm going to leave you with a few final thoughts on the impact of AI and the progress and some new challenges. And so I live in Arizona, in Phoenix, and in Phoenix, our streets are now inundated with self-driving cars. And so Waymo has a huge presence there, and you're driving, and there's almost no commute that you take without driving next to a self-driving car. And you need to start asking yourself, what's going to happen when motor vehicles no longer collide? Because regardless of how safe or unsafe self-driving cars are now, they will get this right, and it's not going to be 50 years from now. Okay, these cars are on the street now, and you will start to see self-driving cars being the dominant presence in our lifetime. So what does it look like when we no longer have car collisions? Well, I will tell you that even though falls make up 40% of our work, motor vehicle collisions make up 12%, and pedestrian struck make up another 5%. And what are you going to do when you drop out this portion of your patient trauma population? If you look at patients with a mechanism greater than ISS greater than 25, you'll see that almost half of traumas will no longer occur. So if your trauma volume, you're taking care of 200 ISS or 100 patients with an ISS greater than 25 every year now you're going to have to do it with 50 and you're going to have to stay good. So how are you going to do that? Well, AI contributed to the problem. There's a good chance that AI will be able to help you solve the problem. And I think, the problem of maintaining excellence in clinical care as our trauma volume decreases, we're going to have to do more with simulation and probably more with virtual reality. But I think we'll also have to do more with AI assistance. I think that in the future, it's not going to be unusual that you walk into an emergency department and you see patients with augmented reality glasses to help guide you, help remind you of what's going forward. Thank you. I appreciate the time. Thank you, sir. All right.
Thank you, David. When the self-driving ATVs get to Arkansas, we'll be in really good shape. One of our heroes in trauma care, Dr. Wayne Meredith, came and inspired us at the Children's Institute, and he said, "The only way we don't succeed is if we quit trying." And nobody in my professional career has tried harder than David Notrika. So thank you again, David, for